Welcome to Grad Rounds. Today's speaker is Dr. Richard Cordle, Department of Gastroenterology here at Carilion. Dr. Cordle grew up in Richmond and after finishing undergrad at UVA, went on to WashU in St. Louis Medical School and returned there for fellowship at St. Louis Children's Hospital after a 3-year residency at Wilford Hall Medical Center in the United States Air Force in San Antonio, Texas. After fellowship, he returned to the Air Force and served on staff there as a pediatric gastroenterologist. He came to Carilion in 2002 when pediatric was based in the community hospital, and before there was a medical school and a Starbucks. Really? There was no Starbucks? We're not finishing, spending his time finishing charts. He is focused on his family, which is both here and also as far away as Nashville, Miami, and Wilmington, Delaware. Please welcome Dr. Richard Cordle.
Thank you for coming, and those who are online. So today, to get us started, rather than just jump into the title, I wanted to just do a little intro. So if you look at this map, this is from the CDC. This is, unless you've been living in a rock, or in a cave, you know that there's an obesity problem in the world. And this is a breakdown of the prevalence of obesity in adults throughout our nation. And you can see that there are some places like Louisiana, Oklahoma, and then next door here in West Virginia, which is a foreign country, and I'm trying to dig in for John Mark. So the prevalence though is probably about 1 in 3, 30% roughly, and then in children, when you look at that, it's about 20%. So 20% of children, 1 in 5 that you see are obese, and so obesity has consequences. High blood pressure, as you know these things, type 2 diabetes, prediabetes, insulin resistance, sleep apnea, musculoskeletal complaints because the frame can't physically handle the weight that's being put on it. And I don't know about my colleagues, but I saw 3 cases of gallbladder disease in just 1 week last week. So I think the incidence of that is on the rise. There's social stigma attached to it. So people who have obesity are often bullied or have issues with that. If you want to join the military, and you're obese, you have trouble meeting weight regulations. And so that's an issue. And then finally, although this isn't listed on the CDC website, fatty liver disease is a problem of obesity. And so that's what we're going to talk about today. So we're going to take the fat out of fatty liver disease. And I don't have any disclosures, and this is a lot of words. What we're going to do is to go through the nomenclature. So actually, the name fatty liver disease or non-alcoholic fatty liver disease has changed. And so in a sense, fat was taken out of the name. And so we're going to talk about that and why that was done. Secondly, we're going to look at risk factors for people who have fatty liver disease and how to make the diagnosis. We're going to connect it to some of those other issues that we saw come out with being overweight. And then talk about management and interventions that we can try. So our history of the name starts off in 1980 when Dr. Ludwig coined the term NASH. He recognized a group of patients who had evidences of alcoholic liver disease, but reportedly were not drinking any alcohol. And this received no support amongst other doctors, because they said, how can you actually know that somebody has not had any alcohol and that this isn't still related to alcohol liver disease? So NASH stands for non-alcoholic steatohepatitis. Because it was not well accepted, he had to get this published in Mayo Clinic proceedings, which I'm not slamming that, but not well read. It's not like a New England journal. And as we go forward, we see that NASH is actually downstream in a continuum of problems that starts off with a normal liver, and then over time through a lifestyle changes, and there may be fat deposition that develops such that you develop fatty liver disease. And then in that subgroup, there's even another subgroup that develops out of that from time of further increase in fat deposition and perhaps oxidative stress. So like if you have obstructive sleep apnea, perhaps that's putting ischemic stress onto the liver, and that can cause oxidative radicals to create inflammation. And then with that inflammation, you start to lay down scar tissue. And as you lay down scar tissue, then you might develop cirrhosis. So I want you to keep that continuum in your mind as we go forward. Starting off with normal, go to fat, go to hepatitis or inflammation, go to scarring, go to cirrhosis. And so if you think about it, with 30% of adults are obese, and that's our prime risk factor for fatty liver disease, we're shuttling into the pipeline a whole host of people who are now developing cirrhosis. If you look at that continuum, even if I start off with 100 people who have fatty liver disease, 10 of those on average are going to have NASH or hepatitis, and then maybe 1 out of that 100 roughly are going to, these are not really well published figures, but just sort of a way to think about it. 1 in that 100 will develop cirrhosis. So if I'm talking about 30% of the nation, 1 in 3 adults, that's a huge number of people now who are developing fatty cirrhosis. And in fact, in females, it's actually the #1 indication. It's for transplant. In males, it's second only to alcoholic liver disease. So it's a huge public health problem and is only growing. However, there's problems with the name non-alcoholic fatty liver disease. And so the term non-alcoholic failed to describe or indicate what is going on, what is leading to the fatty liver disease. It just doesn't tell us. It just says, okay, this is a subgroup of people who have fat in their liver. And I didn't really, let me go back, now you did it, to this. I meant to point out, this is a liver biopsy, and what you can see here are these white areas. This is what's called macrovesicular steatosis or macrovesicular fat. The fat is crowding out the nucleus, pushing it to the side like this, and that's what you see. So this is actually what you also see with alcoholic liver disease. But how does this subgroup, how does it get there? And then there were people who had fatty liver disease who did drink alcohol but had other features of metabolic dysfunction. How do we use the name to instruct us about that group? And then in pediatrics, nearly all patients were excluded because they weren't drinking as much as it takes to make alcoholic liver disease. So there had to be a change in the name. If you're under 10 and you have steatosis in your liver, you're not pounding brews. Okay, so that's a different group. In 2018, this English physician coined the term pediatric fatty liver disease, type 1 and type 2. And so type 1 would be inherited metabolic diseases, medications, nutritional factors, and we're going to look into that in a little bit deeper. The second group would be the ones that we're more familiar with as having fatty liver disease associated with obesity and our typical non-alcoholic fatty liver disease. So the name had to change. And so it did so. And so consensus, a panel met in 2020 and proposed to rename it metabolic associated fatty liver disease. So now NAFLD became MAFLD. And they were trying to help clarify the diagnosis. How do we study this population and study them with studies, like research studies, or in the lab? How do we, so we know that we're dealing with the same type of individual as we go forward. We don't want to confuse people and interpret clinical trials and say this people responded, these didn't, because we mixed up the names. And so, but however, if you use the term like metabolic associated fatty liver disease, a lot of fatty liver that we see in children is metabolic, not related to non-alcoholic fatty liver disease. So we weren't done. So the fatty was stigmatizing. And so NAFLD then became MASLD. And this is in 2023. Now, what does that stand for? And so it stands for metabolic dysfunction associated steatotic liver disease. And I tried this on a patient, and they said, "Is this what you're saying? Supercalifragilisticexpialidocious?" The person looked at me like, "What in the world is he speaking in tongues?" And so, but it does help when you think about it. And so the reason for the term is so that we can start segregating people into categories that we can study much better. And so let's look at this. We used to use the term fatty liver disease. Now we use the term steatotic liver disease. And this is all people who have fat in their liver. And so if you look over here on our far left, this is our group. So this is our group with MASLD. And then these people go on to develop hepatitis or inflammation. Remember our progression. Now that's no longer NASH, it's MASH. And that's what you're used to. But what's new is this group in the middle here, and this is what's been helpful, is this is a group who has MASLD, but also drinks. And so if you're on the left side of this continuum, this is if you drink 140 grams and you're a woman in a week, or 210 grams and you're a man, then you get put on this slide. If you get more and more alcohol, you start becoming more and more like alcohol-associated liver disease. So if you're sitting there thinking, I wonder if I'm one of those. So this is just in case you're interested kind of thing, because I was. How much alcohol is that? So 14 grams. So if you think this would be 14 grams times 10 in a week. So 14 grams is sort of the standard. So a can of beer or a glass of wine or a mixed drink, each of those are about 14 grams, and then you can kind of see on this spectrum how much it would take to start to develop alcoholic liver disease. So this isn't really a category that we're spending a lot of time in kids, but I just wanted you to see why this change, another reason for this change in nomenclature. On this end, so on this side, these are patients that we see. And then on this side over here, these are other patients who have fat in their liver that we're going to look at a little bit. So these are people who might have a medication that leads to fat in their liver, or some genetic disorders where fat is a key component of their pathology. And then there's some miscellaneous things that we're going to go over. And I just want to let you know, over here, cryptogenic, this isn't something that we see a lot in kids. There's something called lean fatty liver disease, or lean MAFLD. And these are adults. About 40% of the adults who have fatty liver disease don't always reach BMI criteria for fatty liver disease, the metabolic dissociation type. And so these are people who you wouldn't normally categorize just by physical exam. So just letting you know about that. So how do we use this clinically? So to start off with, you have to first have steatosis, and steatosis is defined as greater than 5% of the hepatocytes, liver cells, having fat in them. Okay, so how do we figure that out? How do we diagnose somebody with fat in their liver? Well, you could get that by imaging, or you biopsy them. And so it starts off more with an imaging diagnosis rather than a lab. So we start off, and then you have to have, in addition to having 5% or more steatosis in your hepatocytes, you have to have greater than 1 metabolic criteria. Now, this is the adult criteria, and I'm going to break this out for us later. But one, there's a weight criteria. Then there is, or you can have insulin resistance, or you can have hypertension or lipid-related disorders. And we'll go over that more in depth. If you have more than one of those, then you could have MASLD. And then we'll ask, MASLD is a diagnosis of exclusion. So are there other causes? Wilson's disease, lipodystrophy, we're going to look at some of those, pull some of those out in a little bit. So if you don't have any of those, then you dump into this category here. Okay? Sorry, I got ahead here. So that's on this side. What if you do have another cause? Who are these people? Not alcoholic in our patients, but that's when we start thinking about, is there a genetic disorder? Are they on a medication? Are they on TPN? Okay? So that is a helpful way of thinking. I like to look at algorithms in my mind. So when we meet people, what is it like in kids? How many people do we see that might have MASLD? And so I'm going to be using the term NAFLD and MASLD interchangeably because most of the research in the past or most of the studies were looking at NAFLD. So if you look at adults, 1 in 3, so 30% in this room, maybe, so have fatty liver disease. And then of that group, 10% of that group may have NASH, which is down that continuum. So how do we know if a person has fatty liver disease? We talked about looking at imaging or a biopsy. Are there non-invasive markers that can help us to diagnose? How can we track these people out over time if we have to biopsy them to track them out, or we have to do some type of imaging study? What about alanine aminotransferase, ALT? That's usually very helpful and is used many times and is a correlate to fatty liver disease, and we're going to look into that in more specifics. Ultrasound can be used, but it lacks sensitivity, specificity. MRI can be used to try to get at that, but way more expensive. And of course, liver biopsy is there, but it's invasive. So if you look at pediatric prevalence, then if we really want to make a diagnosis, though, we actually have to have tissue to do it. So one study, probably the hallmark study for figuring out how many people have NAFLD, was done in San Diego, where they looked retrospectively at 742 children who had died, and they did autopsies on them. And NAFLD was defined, as we said, greater than 5% with fat, and they found an overall prevalence of 10%. 1 in 10. 1 in 10 of the children that you see has fatty liver disease. And so this study was done in 2006, so probably maybe higher today. And then you break that number down into age differences. You can see that toddlers, 1% of toddlers perhaps have some fatty deposition. And then when you become a teenager, 17%. Now, an interesting thing is that they broke it down by ethnic background, and you can see that actually very unlikely to have fatty liver disease when you're black, but much more likely when you're Hispanic. And maybe this is probably deeper than social determinants of health, and so this probably is some type of genetic feature of that. Now, if you're obese, look at that number at the bottom. If you're obese, 38% of the patients that you see with obesity have fatty liver disease. And remember, fatty liver disease is sort of the funnel at the top, funneling down into that cirrhosis. Okay, so we've talked about the name change, and we've talked about the prevalence or the epidemiology of it. And so how does it work? How do you make this liver here into that? Okay, so this is a healthy, nice appearing liver, and then this thing here that's full of fat. Okay, so this is how you do it in ducks. So if you want to make fatty liver, this is how you do it, and it's done. So this is they usually use this is done a lot in France, but it's done internationally. There's a restaurant here in town because I Googled it. There's a restaurant here in town. I guess we're not supposed to say like proper names, but there's a restaurant here in town that serves this. It's called fatty liver. It's called foie gras, and which means fatty liver. Foie is liver, and so this is how they make it. So in order to make it, you take a goose or a duck and you force feed it. You force feed it over. The duck he doesn't look unhappy. And so he's getting food and he's kind of looking at us. And then, so then you fill him up with that, and then you harvest his liver, and it looks like that. So there's a fatty liver, and then you put it on a plate and you sear it, and you put it. And it's supposed to be a delicacy. It's supposed to taste really good. But anyway, that's foie gras. There is a restaurant here in town. I'm not going to give the name sidecar, but it's in town. So I thought that was interesting. So this is how you do it in adults. And so excess energy will be stored as fat and will increase your amount of fat in the liver. So just looking at this picture here, you can see he's sedentary. He's got his remote. He's transfixed by the TV, and he's got all these calories in front of him. If you were to pick which of those components in that picture is the worst?
Sedentary.
Sedentary, I heard. What else?
Calories.
Deeper than that, Allie. Which of these things?
The fructose,
The donut?
the high fructose corn syrup in the soda.
We'll call that a soda, not coffees. Coffee, definitely not, because that's my world. So I heard fructose, and that is actually the answer. So fructose, and this was actually, I love this slide because I'm very visual, and this is very helpful to me. So fructose leads to increased fat production within the liver and insulin resistance. So let's look at this. So typically glucose enters, and we can imagine over here on this side glycolysis occurring. And so glucose enters and goes down through here and creates a pathway toward actually making fat, but it's regulated. Insulin will turn it down, whereas fructose enters the liver cell and is unregulated and becomes an unregulated source of carbon backbone for glycerol 3-phosphate, which is your how you make triglycerides. So you can see this is funneling right into fat. And then this is crucial, is that as you increase in fat, you increase, the liver cell says no more. And so it becomes insulin resistant. And then just remember this visually, we're going to come back to it, also is involved with packaging and sending out VLDL. Okay, so to back this up, in animals, reducing fructose but not glucose improves fatty liver. So fructose being a component of glucose. So this is a study in humans. This was done about 5 years ago. And it was a very simple study. 40 obese adolescent boys were randomized, 20 to no intervention, 20 to just taking free sugar out of your diet, down to about less than 3% of your daily calories. So this isn't carbs, it's just free sugar. So, and as you remember, sucrose is glucose plus fructose. So these people were definitely diagnosed with fatty liver disease. Remember, the diagnosis is a challenge. Unless you do a liver biopsy, you know if you do a liver biopsy that they have it or don't have it. So they did liver biopsy. Greater than 10% was what they used for their criteria for how much fat was supposed to be in there. And then they also had an ALT greater than 45 on average. So they just did 8 weeks and then they re-evaluated. And they used an MRI to follow the amount of fat that was in the liver, and they showed that there was a significant drop in the amount of steatosis. This is 8 weeks of decreasing your sugar. Just 8 weeks, you've lessened the you've lessened the fat, no improvement in the non-treatment. Your ALT dropped, your in that group, but not in this group significantly. Your cholesterol dropped and your weight. So this is just 8 weeks. This is just sort of just to show that just dropping sugar alone can make a difference. So we talked about how, in terms of what makes fatty liver disease, that overwhelming your body with calories, particularly sucrose, can be a problem, particularly within that fructose. There's some genes that have been looked at as being connected with fatty liver disease, and the one that you might read about, I just put this in here so as you might read, you might hear about it, you'll see it. And I don't want to go granular on this too much, but just know that there are variants within this gene in particular that are associated with NAFLD and interestingly enriched in the Hispanic population. Remember, Hispanics on that autopsy study, the majority or the highest percentage was within the Hispanic population. So genes, too much sugar, but what about your microbiota? Since that causes everything nowadays. And so looking at murine models or mouse models, they took the poop from a non-diabetic woman, spun it down and got the bacteria out of it and gave it to mice and put it in there. These are mice who did not have steatosis and they developed it. So that's, I think, very interesting. And how would that happen? Perhaps the enterotoxins or the cell walls from the bacteria could be shuttled up through the portal vein into the liver, and create a oxidative stress, create inflammation within the liver. So there are also, in addition to those things, antenatal contributions, or even things that happen in infancy. So looking at non-human primates, mothers who are fed high-fat diets, their livers of their children, of their offspring, also developed fatty liver disease. And actually there's some human studies that show that the BMI of the mother at birth correlates with development of fatty liver disease. Just like we talked about microbiota, if you are breastfeeding, you increase your microbiome diversity within your colon, and you have less steatosis, perhaps. And then another factor is that if you're a low birth weight infant and you have a rapid increase in weight over those first several months to a year, you also have an increased risk for insulin resistance, central adiposity, and maybe even fatty liver disease. Okay, so we talked about pathogenesis. We've talked about so a little bit about the epidemiology. So now we're going to bring it down to the patient entering our office. What do they look like? So this is a 20-year-old paper, only about 36 children, 21 boys, 15 girls. Just to look at the characteristics for this, you can see that ALT elevation is seen in the majority of these patients. 83% were obese. A couple already had type 2 diabetes. 15 of 36 had hepatomegaly. Half had abnormal lipids, acanthosis, darkening of the skin around the neck, and a third. And then they did liver biopsy, and that is what I wanted to point out. You can see at diagnosis, many already had advanced liver disease. One with cirrhosis. So physical examination, most of these patients do not have any signs. This would probably be better to set as physical exam, just signs. So usually they're asymptomatic. These are incidental findings on a liver panel. You do a CMP and you find the elevated ALT. They typically are asymptomatic. However, you can have some right upper quadrant pain and some abdominal discomfort. So I'm not saying that every patient that we see that's overweight and has right upper quadrant pain has fatty liver, but something that I was thinking, I actually think I've seen that quite a bit. So then you want to look for evidences of chronic liver disease. So this is palmar erythema, and this is a spider angioma. These are just from capillary dilation within the perfusion that arises when you have portal hypertension. You might find hard liver in the right upper quadrant if you can palpate through the adiposity. You might find splenomegaly, the same thing, or you might see that on an ultrasound. Low platelets would be a sign of hypersplenism and perhaps advanced liver disease. I would say you're not going to see, in general, any of these things in most of your fatty liver, but when you do see them, you want to start thinking about referral. But I just wanted to put this out. We'll come back to these signs in a little bit. Back to this demonstration. With this new nomenclature and diagnosis, so we've talked about how they might look. It starts off with imaging. And we've already talked about how imaging was not, with an ultrasound, was not real helpful, how an MRI is expensive. So what are we going to do? We don't know. So 5% of the hepatocytes have to be elevated. So are you going to use an ultrasound to look at that? Or are we going to have to do an MRI? So all we really have is ultrasound to do. And we'll look at this a little bit in depth, but what ultrasound shows is increased echogenicity. And so you're looking for, does it look bright on that? So 5% hepatocytes with steatosis, and then greater than 1 in 5 cardiometabolic risks. So is there another thing that we could do? So wouldn't it be more practical to just select out who has the risk factors and find something else? Maybe we can screen them with a lab. And so let's first look at the risk factors. And this is in kids. And just think about this. So BMI greater than 85%, or you have a central adiposity. We don't really measure waist circumferences in people. But if you see that's another, that would be one of those risk factors. So weight, overweight. Number 2, insulin resistance. So what's their A1C? Do they have prediabetes, or do they already have diabetes? You can use a fasting glucose or a random glucose if it's non-fasting. Do they have hypertension? So it's greater than 95% of the blood pressure if you're under 13, but if you're greater than 13, just remember this number. So 130 over 80. Or lipids. So triglycerides are to be elevated. And then if you're less than 10, 100 or higher, or greater than 10, 150 or higher. Or is your HDL less than 40? So if you remember metabolic syndrome, these are the features of that metabolic syndrome. So if you have this group, you're looking at somebody in your office and they have this group, reasonable to screen. Screen them when they're 5? No. Screen them when they're 9 to 11. That's pretty much the recommendation. So an ALT with a risk factor would be the way to screen. So what is abnormal then? So we're going to send an ALT. So what's abnormal? This is the Carilion reference range. And then let's take a little rabbit trail for a second. So particularly with liver labs, the reference ranges from Quest are not always right. So they took Wendy, I know the lab is your world. So they took 180 this is just a little detour. They took, I think it was 180 or 150 for the top limit of normal for alk phos and put that in there for about 18 months. And we were getting all kinds of referrals. I mean, normal is up to 350 in kids. And so just be careful with that. So in our reference range, 49 is the high, but nationally there's been some papers that show that this is more than normal. So 22 for girls or less, or 26 for boys to capture people. So when you're thinking about, oh, wow, look at that, they're like 35. Doesn't mean necessarily something's wrong, but just your antenna goes off. Let's follow this person a little bit more. So how valuable is an ALT then? So let's look at that a little bit more in depth. So this is a paper done about 10 years ago, and I just put this in here to show how they segregated people. So this kind of is trying to mimic what would happen clinically. So a person sees somebody in their office, they screen them with an ALT so that you can see that they're overweight and obese. They've screened them, and they refer them. So they get referred to a gastroenterologist, they examine them, they repeat the labs, and about 74 fell out. They had 273 left, and they biopsied them. Of that group, the majority of those ended up having fatty liver disease. So then to break that down, if you used 2 times the upper limit of normal, so that's 44 in girls, 52 in boys, then you really increase your sensitivity, not specificity of finding fatty liver disease. So 88%, and then it actually selects out even people who might have more advanced disease. And then when you use even a higher number, greater than 80, particularly if it's persistent, you can see that actually you might be selecting out a population that has advanced fibrosis. So, however, ALT may underestimate how much fatty liver disease is out there. So this is a paper done in 2014 where they looked at people who had mild or no elevation of ALT and did biopsies on them. So 19% had normal ALT, 81% had mild, and then they repeated and they had some that had elevated, defined as greater than 2 times the upper limit of normal. So look at this graph. This is if they just had, on biopsy, if they just had fatty liver disease, and the black means normal ALT. So so the ALT may actually, even though we've cut down the reference range, we might still be missing people who have fatty liver disease. And this is looking at fibrosis stage, and you can see that if you have a normal ALT, the chance of you having fibrosis is 0. Whereas if you have normal, you might have early evidences of fatty liver disease. So maybe the ALT will help us to even determine those who have a more advanced disease. So how do we use this? So this is one of those takeaway. This is take this away as you leave. If you remember nothing else, you'll remember the duck, and you'll remember this. So so we're going to use ALT. We're going to treat people between 9 and 11, and If it's normal, what do you do with that? Do you just leave them alone and say, okay, it was nice seeing you, go off to college? So then, no, you want to repeat it in a year or to 3 years. I had an e-consult recently about someone who had an ultrasound done, showed fatty liver, and they had normal ALT. What do you do with that? And that's not as clear, but that's not somebody, that's also somebody that you don't want to just let go. You probably want to follow that out, maybe in a year or so. So what about mild elevation? This is greater than 2 times upper limit of normal, but still less than 80. So this is from the pediatric, from the general peds standpoint. What do? You might want to start talking to them about lifestyle interventions, weight loss, and then repeat it again in a few months, and then see where they stand. If you, and then if they still persist, looking all the way over here to the right, or if you have greater than 80, you still want to start your process of lifestyle, talking to them about weight loss. But then might be the population that you send to us. You have to wait a while to get in, but you can send them to us. So, and then there's this group here, and this is when you see, like if you're sending labs on somebody who's sick, and you're worried, somebody comes into the emergency room, they have scleral icterus, and they might be vomiting, they might be sick, or they might have right upper quadrant pain, some other kind of sign, and you send it in, oh, their ALT is elevated. What do you do with that? Well, you want to assess liver function before you decide what your disposition is. Check your coags, check an ammonia maybe, make sure that their glucose is okay, and then you're going to repeat that soon. You're going to make sure that that's resolved, perhaps maybe after the viral syndrome is gone. And I've seen this a lot where people have come in, they got referred from the pediatrician after in the midst of one of these viral episodes. So I usually will just repeat it before I start doing a lot of other work. And a lot of times, not a lot of times, but it'll be normal. You remember that algorithm, 77 or so of those people out of that 350 were normal when they repeated it. Okay? But don't get caught in a rut. So let's say you have an ALT that's elevated, and let's say that you've already said you're tired of waiting to get into our clinic. So you send an ultrasound, you want to just do something. So you send an ultrasound, hey, it shows steatosis. I got fatty liver, hey, you're fine. You're not gonna, most of the fatty livers are fine. We'll get you in eventually, but don't get caught in the rut because not all steatosis is metabolic associated. I can't even say it, metabolic dysfunction associated steatotic liver disease. So, so let's look at this chart here for a second. So there's inborn metabolic disorders. There's medications that can lead to this, dietary causes, parental nutrition, or nutrition lack, or even hepatitis C. So I just selected out a few on this graph here, on this chart, just to look at, just because I thought they were interesting. If you see younger age, lower BMI than makes them into fit this group, they don't have risk factors, it seems like it's a little bit more accelerated. You might have history that fits one of these categories, then you might want to doubt your diagnosis. So this is lipodystrophy. I actually have never seen a case of this, but these are people who have normal body fat who actually have significant hepatic steatosis. So I don't know. This is from Up to Date. These people are creepy, but I don't mean that the people that have lipodystrophy. I mean this. I don't mean that. I mean this picture. So what they're trying to show you is that there's the abdomen is scaphoid. There's no fat. This is like well defined. This guy's a little buff, and then there's no fat on this person, and also there's acanthosis. That's what they're trying to say. Oops. There's inguinal acanthosis is why this picture is like that, and they also will have it in the neck. So why does this develop? So these are people who have problems in their adipocytes from getting free fatty acids into them. So there's this high circulating free fatty acids that go and home into the liver and fill the liver up with that. They become, because when you fill the liver up with fat, you become insulin resistant, then they also have problems with that. So this would be a lean person has fatty liver disease. Something to consider. This actually is a little bit more common, although I've not made a diagnosis of this either. But this is lysosomal acid lipase. In a baby, it's called Woman's disease or Wolman syndrome, and an older person cholesterol ester storage disease. Typically, in our awareness of these were younger children who were failure to thrive, diarrhea, hepatosplenomegaly, but older might have milder symptoms, and they can be picked out by having a higher LDL and xanthomas. So you can see this, this is a child who has that, and you can see this yellowing around the face. So also with A-beta, hypobeta lipoproteinemia, so what this is a defect in the microsomal transport protein. So when fat comes into the intestinal cell, it has to cross over to the cell and become reesterified to become triglycerides. And so this won't let you do that, so it fills up the enterocyte with fat, and you don't digest it, so you become malabsorbed and you have failure to thrive. That's the early version. And you can have some of these spin-offs from that, cerebellar dysfunction, retinal degeneration. But with milder cases, you can have steatosis and have milder symptoms. Well, why is that? Well, if you look at over here, this protein is used in packaging up VLDL and exporting it out of the cell. So these people can't export VLDL and it accumulates within the cell. Nobody in this room may ever see these patients, but I just thought it was interesting to think about those things. But expanding our differential from genetic disorders, these are a little more common. People who have been on steroids or valproic acid, some of the antipsychotics. This is treatment for HIV. These are antiretroviral treatments. And interestingly, just side note, those patients will look like a lipodystrophy patient, the HAART patient. Or things that we're even more used to, malnutrition can actually lead to steatosis. And so you're going to be lean looking in that person and actually have fatty liver. So if you see mild elevation of liver enzymes, perhaps even in your underweight, that could be a problem. Parenteral nutrition can also lead to steatosis, particularly if you give too much glucose in your parenteral nutrition. Hepatitis C has been associated with it. So get in your mind, atypical person with fatty liver, maybe I should think more broadly. So we talked about ALT in terms of making the diagnosis, and then so there's imaging. I can look at the time, we're going to start shifting. So so this is imaging. And so I wanted to, this is a picture I showed earlier, and so it's increasing. I don't know if you can appreciate, but from here to here, it's brighter. And then also, I can see these blood vessels here within the liver. This is the liver, by the way. And so, so you can see these blood vessels less. It's a little bit brighter. Now it's almost effacing the blood vessels. Hey, they're gone. So this would be, you can see progression of the steatosis within this. But this is very inexact. It's very easy to get, but it's hard to get some strong data with that. MRI is actually much more sensitive, much more specific, much more helpful, but very expensive. We don't screen or use MRIs very regularly to help make the diagnosis. So really, going back, cardiometabolic risk factor and an ALT get you started. And then liver biopsy is the gold standard. So if you really want to know, does somebody or does somebody not have fatty liver disease, particularly when you're talking about medication trials and stuff, you need to really know that you had it. You can see that ALT is not accurate and that ultrasound isn't accurate. And so liver biopsy is the gold standard, and MR could be helpful also. And again, you remember the little white circles would be your fat. So we're going to look a little bit at histology, just because children are a little different. And just to quickly do that, I hope you can see there's kind of two patterns here. This is the central vein. So you know that the portal, that blood flow comes in through the portal triad, circulates through the hepatocytes, and then exits out the central vein on the other side, and then goes back into the hepatic vein, back to the vasculature. And so these are listed in zones. This is zone 1, zone 2, and zone 3 is around this. So zone 1, if you see this, you can see a collection of fat in here. This is very consistent with early children. You don't see this in adults very well. This is more the adult pattern where the fat is more in the center, like zone 2 and 3. And so that's what we see. And so there's actually some inflammation in here too. And so when you see that the children are being diagnosed with fibrosis and inflammation early, like we showed earlier, then they could be having this, this type of pattern. If you have elements of both, that actually might make for more of a progression. So only liver biopsy can actually accurately make the diagnosis and help you to follow fibrosis in time. Okay, so let's just quickly, how do you follow fibrosis? And so how do we know, just so you can visually see it. So this is normal, there are scales that help us to know how is a person progressing towards cirrhosis. And so this is a fibrosis score. I'm just showing this real quickly. Here's the portal triad. And then you can see this is a Mason's trichrome stain, which stains collagen, which is fiber. And you can see that there's some around, this is sort of normal. And then you can see that it's getting a little bit larger. This is what's called an F1 or a stage 1 biopsy. This is now there's septa developing. This is progressing. This is an F2, and this is F3. Now this is bridging. So it's bridging fibrosis. And then this is cirrhosis. So you can see these nodules in there. So that's just showing you the progression in time. And I do that to kind of set the stage for how do we figure out the natural history of people? How do we follow these people over time? It's been well worked out in adults, what it is. So this is, I think, actually a very helpful table to look at. So this is if you have fatty liver disease and if you have NASH, what happens to those? And you can see the prevalence, that it's much more common to have NAFLD, 10% or so will have NASH of those patients. And then what's the fibrosis progression? So one stage of progression over 14 years if you have NAFLD. However, if you have NASH, one stage of progression over 7 years. So very slow, but if you remember our funnel diagram, our funnel conception, if we're talking about 1/3 of the nation with fatty liver disease coning down into cirrhosis. So in a 10 to 20 year period of time, 3% of people with fatty liver disease will develop cirrhosis, and probably 6 times that in those who have NASH. Increased risk of cancer in patients who have NASH, and mortality, all comers, and a lot of that's from cardiovascular problems. And then this is 2021. There actually is now an approved treatment, but it's not that robust. So, and then in adults, if you lose 5%, you might be able to reverse some of the fatty liver disease, and then you need to lose 10% of your weight in order to reverse NASH. So what about the natural history in children? What happens? Remember, they have advanced disease when we actually go and do a biopsy. Do those patients go on and are worse later in life? And wouldn't we be, if they're that advanced when we first see them, wouldn't we see more cirrhosis during their teenage years? And the answer to that is no, they don't advance. And so why is that? We don't know. So we don't really have a lot of good data about the natural history. There's one study that looking at the placebo arm in a study that was comparing vitamin E, metformin, and placebo. And they found that a third progressed to disease, but half got better. So it's really hard to wrap your hands around what happens to children, and that's important when we think about treatment also. So does an earlier presentation lead to more likelihood of progression? Does fibrosis, if we know that fibrosis in adults at diagnosis indicates more severe course, but what about kids? Is there a way to select them out with some markers that tells us that they are heading that direction? How do we follow these people? And so how do we track them? Ultrasound we showed, not real helpful, although we did see progression in that one thing. There are fibrosis scores that have been published, many of them. None of them have really been shown to be accurate in kids. So something called an APRI, an AST to platelet ratio index, very easy you can get these calculators online. There's a pediatric fibrosis score, enhanced liver fibrosis score, the only ones that have shown some promise, but they're not accurate. So you can send them to, they can do an ultrasound-based scan where they look for liver stiffness. The papers for kids, the numbers are too small to say this is validated, but it seems to hold promise to differentiate those who have lower stages of fibrosis to those who have later stage. And that's why I was showing you all those pictures about fibrosis. There's an MR, which is helpful, but you can bet that that's going to be 10 grand every time you order that. So if we go back to that ALT study, if you had an ALT greater than 80, then you actually had an increased risk of already having advanced fibrosis. So we might track ALT. So who do we biopsy then, since that's really the gold standard? So we biopsy all these people and follow them out. Well, that's a lot of invasion. So who would we select out? Perhaps those who have persistent ALT elevation greater than 80, or FibroScan evidence, or maybe they're atypical. They're one of those younger kids who are lean, or maybe they're already showing some of those signs of advanced liver disease that we reviewed earlier. And then as we're following these people, we want to think about some other health-related concerns. If they're going to go on an advanced liver disease, you want to make sure that they're vaccinated with for hepatitis B and A, because you combine those two, fatty liver disease and a viral hepatitis, they're going to do worse when you have fatty liver disease. 2/3 of patients who have fatty liver disease have hyperlipidemia of some nature, so you want to track that. I think this is important. 20 to 40% of those who have mast cell have hypertension, and I don't know that we always check blood pressure, not with our clinic, but that we're checking that on a regular basis, but perhaps we should. And then following them for getting an A1C would also be useful. So we talk about tracking them. Now we're going to go into 5th gear now and do treatments. And I'm sorry, this is probably the most important part, but we're going to go over this. So in lifestyle interventions, there's no uniform intervention that's been shown to clearly make differences, I should say no specific diet. However, it has been shown that sugar sweetened beverages, since that's has high fructose corn syrup, it is driving the lipid development within the liver. That's probably something you can tell people. And I think seeing that slide with the pathogenesis is helpful for me to know, okay, when you're sitting here, you can actually talk very dispassionately about it, and then they don't feel judged. Okay, just cut this out, just take sugar out, and start. We've shown that this is a real problem. We have our own healthy lifestyle clinics, and it's been shown that those types of clinics have better outcomes than just regular counseling. And so if you just make a 10% reduction in weight, you can resolve NASH in 90% of adults. Exercise is very helpful. Somebody said exercise earlier, and that is helpful. And when in a study where they didn't make any dietary change, both doing weights and aerobic exercise reduced hepatic steatosis significantly. And then there's medications. So in that same trial that showed you it had placebo, where they tracked liver biopsies, they were comparing metformin and vitamin E, which had been traditionally used, and because we were frustrated, we didn't have anything to treat these people with, and so we would get metformin. Hey, vitamin E, it's an antioxidant, sounds good. So let's do those things. And they found that with using 1,000 milligrams a day of metformin compared to 800 international units a day of vitamin E and placebo, no differences. However, there was a difference with NASH. So vitamin E might make a difference in NASH. So once it's that far, once the cow is out of the barn, then you might want to use it in that state. So what else? So omega-3 fatty acids, so fish oil has not shown to be statistically significant, although there's a trend toward getting improvement. Very small number of trials with probiotics, actually. Remember we were thinking about the microbiota, have shown some improvement, but no, the numbers have not proven anything. These are some newer medicines that have been tried. This is a bile acid, but it causes side effects that have limited its role. And then this is the new recent FDA approved. This is a thyroid hormone receptor beta agonist within the liver, and if you use this, actually it's more than just reduction of hepatic fat. It reduces NASH in about 27% compared to 13%. So since we don't have specific treatments that we can use for the liver, so vitamin E doesn't work, metformin doesn't work, what else can we do? And so if the pathophysiology is excess calories, then let's target the obesity might be the way to target this. And so there's a huge guideline that has come out in Pediatric journal. This is in 2023 And I would recommend you looking at it, although it's a great way to go to sleep if you're on a weekend. It's huge, but it does have very good information toward that. And so a lot of this is culled out of that. So looking at metformin, we've talked about it as a direct agent, but what about for weight loss? How is metformin for weight loss? So it decreases your blood glucose within the production in the liver, and it helps with insulin resistance. But the weight loss from it is inconsistent, maybe 1 BMI point. So really the recommendation is only if you use it as an adjunct. There's something called orlistat. Orlistat binds and inactivates lipase, so you can't digest fat. It's only recommended or approved for greater than 12. You take it 3 times a day with meals, binds the fat, and it makes you have the runs. So people didn't like it. I was looking for a meme that about orlistat, because I thought I remember Saturday Night Live doing something on this when it first came out, but I couldn't find anything. So GLP-1 agonists are really the thing now. So it was found when these were being used to help with insulin resistance that it slowed gastric, this is gastric, not gastrus, emptying, leading to early satiety and weight loss. These are some of our earlier ones, exenatide and glutathione. These are not labeled for weight loss. Liraglutide, semaglutide, and tirzepatide have all, I think I'm saying these right, have all had both diabetes and weight loss labelings. And then these two, liraglutide and semaglutide, have been actually FDA approved for greater than 12 years of age. They go by different names. So if you use liraglutide for insulin resistance, it's called Victoza. It's Saxenda if you use it for weight loss. It's a daily injection. It dropped weight 5% or 4.5 BMI points. You have significant GI side effects. And if you have MEN2 or you have a family history of medullary carcinoma of the thyroid, you should be wary. You start off slow and you increase the dose. And similarly, so that's Saxenda, daily injection. And then similarly, semaglutide is a weekly injection. This is the spinoff from Ozempic. And now Ozempic has its weight loss brand is Wegovy. And it's similar complications to liraglutide with the thyroid and that sort of stuff. You have worsening GI symptoms. And again, you progress in time. So really, this is nice to talk about, but they're almost unavailable. They're so popular right now that it's very difficult to get. Insurance doesn't want to pay for it. It's very challenging to get these. So do we just course the darkness, or do we strike a match? So there's some medications. There's phentermine. This is a medication that you get that reduces appetite. There are different dose levels, but it does cause some cardiovascular complications, blood pressure, tachycardia, maybe even some tremors. And so this is only for children greater than 16. You use it for 3 months and you're supposed to stop it. Now that being said, I think a lot of people use that off-label use of continual usage, but you have to worry about this addiction concern. Topamax is an anticonvulsant. It's used for also migraine, decreases your appetite. I didn't put in here, but I should have. Side effects, what the side effect was, but it's cognitive slowing. So these people come in and you almost can see them catch their words. They're really slow sometimes at how they communicate, but effective. But what if you combine those two? And so there's medication where you combine phentermine and Topamax, and you can use lower doses and get better success. It's a teratogen. And just quickly look at this. So this is the mean. So this is odds ratios of improving based on using an intervention. So this is liraglutide here, metformin, orlistat, Qsymia, which is phentermine plus Topamax, and semaglutide. Look at this right here. So just to pull that down, this is almost a 5 times improvement with some of these medications that are significant in terms of weight loss improvement. So then there's surgery, which is targeted for people who have BMI greater than 35 and a comorbid factor or greater than 40. And since these medications are everyone's asking for them, we all have kind of become obesity doctors. Who is doing this? Is it GI? Is it endocrine? Is it general peds? Who's ordering this? Well, since we can't get the medicine, where do we go? And so I had a patient tell me that there's a place in Martinsville that you can go and they'll give you a shot. And so you can pay by the shot and get your, and this is in a weight loss clinic. So you don't even have to be a doctor, and you can go out and get and lose weight. So we're all going to be involved with this. I'm sorry that we've run out of time and I had to rush there at the end. But you can see that this is a public health crisis, actually, that we're funneling these people to transplant, and we need to find means of catching these people, tracking them over time so they don't go on to have fibrosis and chronic liver disease. And then we've looked at some treatments and some therapies going forward. So we're supposed to do questions. So these are not real difficult. What is the new nomenclature? Is it metabolically deranged, anatomic steatotic liver disease, metabolic associated sterile liver disease, non-alcoholic steatotic liver disease, metabolic dysfunction associated steatotic liver disease, or motorically disabled ascites liver disease? D, right. So that was dumb. So you are seeing an 8-year-old with BMI that is greater than 95. So you order labs, you notice that he has normal lipids, normal glucose, normal A1C, normal thyroid, but his ALT is over 120. You detect he has scleral icterus, and his urine is dark. You notice some increased bruising on his legs, and his mother says that he has been falling more. He's more agitated. So you should next just see him in 3 months, further evaluation. B, check an ammonia, coags, repeat labs maybe soon. Go send him for an ultrasound, get an MRI, do an oral glucose tolerance test. What do you think? B, right? This guy's got evidences of advanced liver disease, perhaps moving quickly. Good. Can't catch you all. So which of the following are evidence-based treatments for MESLD? A, just A. So I talked to you about some medications, but just A is the only thing that we really have. So I could have asked you questions for 5 minutes ago, but anything, if you have questions, so just tell them come talk to me. Okay. Sorry.